It is my next task here is really to introduce our first speaker. So it is my great pleasure to introduce to you Dr. Quique Bassat. So Dr. Quique is a medical doctor. He specialised in paediatrics from Barcelona in 2004 and also has qualifications in tropical medicine since 2004 from the University of Barcelona. He also has qualifications in clinical epidemiology from the London School of Tropical Medicine and Hygiene, which he completed in 2008. Later on, he completed a PhD in medical sciences in 2009 at the University of Barcelona with his thesis entitled Malaria in the Paediatric Wards of a Rural Mozambican Hospital and the Clinical Development of New Antimalarial Drugs. He is also a research professor for ICREA, which is the Catalan Institution for Research and Advanced Studies. He is the head of the malaria program at IS Global in Barcelona and also a practicing paediatrician with special interest in infectious disease epidemiology and public health. Dr. Bassat has attempted to combine all his clinical work with biomedical research in those diseases that most affect the poor and vulnerable. His main area of interest has been the prevention and treatment of malaria in childhood, with a particular focus on understanding the clinical overlap of malaria and the other common paediatric conditions, and the use of biomarkers for both diagnosis and prognosis of etiological differentiation of febrile patients, and their risk stratification and prognostic evaluation. His research has also covered the new paradigm of malaria eradication, and he has a particular interest in evaluating the role in elimination strategies. So thank you, Quique. I hand over to you.
Thank you very much. I'll try to be very concise. I know I only have 15 minutes, so the idea is to have a quick overview on the malaria situation. First, a disclaimer, I don't have any conflict of interest. And my only potential conflict is that in 1999, the day I finished medical school, I had an unsuccessful interview with MSF Barcelona. So not that I didn't try to work with you guys. So let's start with malaria who, and I deliberately chose the picture of a pregnant woman and a young child, both of them receiving a blood transfusion. Anemia in malaria is the #1 cause of malaria deaths globally. And those two are clearly the two most vulnerable population groups. And I'm going to focus today on children. And where is malaria transmitted? So this is a figure showing where malaria was transmitted 120 years ago in the 1900s at the beginning. Essentially, malaria was a global disease transmitted everywhere. And this is the situation of malaria today, where transmission has been shrunk between the tropics. And it has been made by the action of man a tropical disease. But just to remind everybody that it's not inherently a tropical disease. It's the action of man that has transformed this disease into a tropical one. This is the distribution of the two main species, Falciparum and Vivax, essentially identical except for sub-Saharan Africa, where there is very little Vivax. Vivax requires a specific receptor in the membrane of the reticulocyte to invade the reticulocyte, and the majority of the African populations are Dophin negative of this receptor. Therefore, there is very little transmission of Vivax among native African populations, but there is a little bit in the Horn of Africa, and that has also some importance. Numbers, Sisha, you've mentioned already numbers, 241 million cases of malaria in 85 countries in 2020, vast majority in the WHO's African region. The number of Vivax cases has been revised and decreased and considered to be only about 2% of the global cases today. That's about 4.5 million. 627,000 deaths estimated to have occurred in 2020. Massive improvements since the early 2000s, but unfortunately a 12% increase since 2019. And I'll say a few words on that regarding the impact of COVID. 96% of all malaria deaths occurring in Africa. The countries that have been already mentioned, 4 countries accounting for more than 50% of all malaria deaths globally. And funny enough, you are treating about 1% of all malaria cases in the world. So you should be very, very proud as MSF. 77% of all malaria deaths occurring in children under the age of 5 in Africa. So essentially, malaria is a pediatric disease affecting mostly children in sub-Saharan Africa. And if we look at the overall causes of child mortality, or causes of under 5 deaths, malaria accounting for about 8% of the global deaths in children under the age of 5. If we were to look at this figure only for Africa, it would be around 20% of all African child deaths. And remember, this is the Africanization of the iceberg metaphor. We have quite good estimates on malaria morbidity and mortality, but as far as we know, we are only seeing the ears of the hippopotamus, or the tip of the iceberg, because many of those cases and many of those deaths are invisible to the health system, and they are occurring at the community level. And we need to remember this, because we need to reach the community if we want to have any impact in our malaria control activities. And what about malaria control? So essentially, there are 3 main strategies. The first one is to reduce the contact between humans and vectors, especially the mosquitoes that transmit malaria. The second one is vector control, to kill those mosquitoes. And the third one is the use of drugs or other preventive strategies like vaccines. And remember that when we use drugs, we can use them to treat the cases already established, or to prevent future cases using pharmaceutical preventive strategies. What about a few of the numbers? Because we have unprecedented success and progress in the last 20 years. 2.3 billion bed nets distributed in Africa in the last 15 years. The number of children under 5 sleeping under bed nets has dramatically improved from less than 2% in the year 2000 to around 50% today. We have an additional 2.6% of the African population protected through indoor residual spraying, nearly 250 million ACTs delivered in 2020, more than 2 billion since the year 2010. And the rapid diagnostic tests, which are the democratization of the diagnosis of malaria, which have significantly improved the way we actually identify malaria cases. 2.2 billion malaria RDTs distributed in the last decade. So amazing progress. Amazing innovation also. Just the fact that we have rapid diagnostic tests, even if they do have some caveats, but we didn't have them about a decade ago. So we should be very proud that we have managed to bring the diagnosis of malaria, democratize it, and bring it to the community level. We have much better bed nets today that can last up to 5 years and don't need to be replaced. We have new families of insecticides, although this is a field in which there is much need for innovation. We have a much better drug today for the treatment of severe malaria. Artesunate is clearly superior to quinine, and we have had massive improvements in the treatment of severe malaria thanks to a better and more fast-acting drug. And of course, we have a malaria vaccine that I will briefly speak about. Important to mention the chemoprevention strategies, particularly targeting vulnerable groups. We have intermittent preventive treatment in pregnancy, which is IPTP, which have what it was formerly known as intermittent preventive treatment in infancy, now called perennial malaria chemoprevention. And of course, we have SMC, seasonal chemoprevention for children under 5 years of age. The combination of these 3 strategies, even if the central one is not massively deployed yet, has importantly contributed to a decrease in the numbers of potential new malaria cases. So this is something that we need to have very much in mind. And even though coverage rates can be improved, this is a substantial innovation and change in regards to what happened less than 10 years ago. And we also have the mass drug administrations, and there are several ways of actually treating entire communities with MDA. We can use it for burden reduction in emergency settings, to reduce transmission of Plasmodium falciparum in very low to low or moderate to high transmission settings, or also specifically targeting PV transmission settings. So other strategies very well explain how to use them in the field, in everyday life. The new WHO guidelines specify very much the cases scenarios, and MSF follows those guidelines typically to deploy them. Just some examples of the numbers. SMC, about 33 million children were treated in 2020 with SMC. This is an improvement of 12 additional million children treated, thanks to the expansion of the program to some areas of Nigeria. As you know, Nigeria is the epicenter of malaria of the world. So anything that you implement in Nigeria is bound to have massive impact in terms of reducing malaria morbidity and malaria disease, and malaria death, sorry. Intermittent preventive treatment in pregnancy, we were having significant improvements during the last 10 years. Of course, the pandemic hit hard and we've had some reductions, but the message here is that we have important space for improvement, because only 1 out of every 3 women are actually receiving the minimum of 3 doses during their pregnancy, which is the minimum recommendation of IPTP. And let me just mention very briefly the new WHO guidelines, because this is important because the previous recommendations had 3 major pain points. First, it was perceived as a very lengthy process to change any recommendation. There were some inconsistent recommendations that were not necessarily applicable to all settings. And there was a suboptimal use of WHO's malaria guidance at the country level. And those new recommendations, who were published in 2022 and have recently been updated a few days ago, address those inefficiencies and enable faster, more flexible, data-driven decision-making for national malaria programs. And they're considered living guidelines, because they allow the rapid and clear dissemination of new evidence through an app platform. They are flexible, so they can be adapted to local contexts, because we do recognize that one size does not fit all countries, and therefore all countries need to be sovereign on their capacity to interpret and adapt those guidelines that fit them better. And this, of course, gives some country ownership for a sustainable fight. Let me give you a few words on the malaria vaccines. This is a very hot topic this year. Let me just show the clinical development of the RTSS malaria vaccine, the only vaccine that we have available today and authorized for its use in malaria endemic areas. But just for you to get an idea, this is the malaria clinical development plan of this vaccine. It took more than 30 years to actually have a product registered and recommended. Just compare it to the red little line, in which during 6 months we had 4 COVID vaccines available to use in humans. So, and not because malaria is not a public health emergency, which was the rationale for running so fast with the COVID vaccines, but just because malaria is not affecting the entire world. And that has delayed unnecessarily the development of these vaccines. The first malaria vaccine implemented in real life was actually given on the 23rd of April 2019 in Malawi as part of this pilot project involving 3 countries, where 2.4 million doses were administered to nearly 830,000 children in Kenya, Malawi, and Ghana. And what we were able to see during this pilot project is that the administration of 4 doses of the RTSS malaria vaccine, including 1 after the first year of life, was feasible. It was equitable because it actually reached better than other malaria interventions like bed nets, the general population. And importantly, it had a massive impact because 1 life was saved for every 200 children vaccinated. There are not many interventions that can actually say that. 40% reduction in malaria episodes, substantial reduction in deadly severe malaria in routine use. So in 6th of October 2021, WHO endorsed its widespread use in sub-Saharan Africa. And the important and big news is that the field of malaria vaccine development is in good health. And we have new products, like, for example, the R21 vaccine that has shown 75% efficacy, not only in phase 2 trials, but more recently in phase 3 trials. We have excellent protection of the sporozoite-based vaccines in human volunteers. We have the prospect of an RNA-based malaria vaccine, mimicking what has been shown for COVID or for more recently for flu. We have excellent results of combining SMC with seasonal malaria vaccination, actually 70% increased protection over either intervention on its own. So malaria vaccine is not the magic bullet, but it dramatically improves the performance of other interventions if applied alongside. And we also have important developments in the field of monoclonal antibodies with very, very good results coming from field trials in volunteers first and also in the field in adults in Mali. But unfortunately, we have many perils ahead. We have funding gaps. It is calculated that we need $3 billion, that we would need up to $10 billion per year until the year 2030 to actually eliminate malaria, and we are only spending about 1/3 of that. We have massive coverage gaps, some of which have been mentioned. Only half of the children are actually sleeping under a bed net, those who are at risk. We still have about 60 million malaria cases which go undiagnosed and untreated. And more importantly, we have important biological challenges. Insecticide resistance, very few new insecticides in the pipeline. Drug resistance, a particular problem in the Mekong region in Southeast Asia, but more recently identified also de novo appearing in places in Africa like Rwanda or Uganda. And importantly, RDT resistance, or that's how I call it for easiness, which is the fact that some RDTs Some parasites do not express the protein detected by the RDT and therefore are invisible to that RDT. And therefore that patient which is tested is not identified as having malaria and can die as a result of not being treated. There is an excellent malaria threats map published by WHO, which I recommend you to actually look at, that exemplifies all of this. And let me finish with COVID-19 and malaria. Let me also stress that the house was already on fire before the pandemic. And in 2017 and 2018 World Malaria Reports, this was very clearly identified. There was a stagnation of progress. Malaria situation was thought to be at crossroads. And if we were not to improve that situation, the risk was that we could go backwards again. And we know how dangerous it is to go backwards with malaria. There was also a fear with the pandemic that the distribution of bed nets, which occurs on a 3 annual basis every 3 years, and which had 2020 as one of the years of big distribution of nets in the continent, was going to be massively hit by the pandemic. And it was like that, this occurred. And there were many other mechanisms by which malaria could worsen the malaria situation, because mostly of the indirect effects of the pandemic and the lockdowns and the restrictions of movement and the air lockdowns, by which it was very difficult to have many of the measures reach the population at need. The worst case scenario, and this is my last slide, was there were a set of scenarios planned. And the worst case scenario said that we could have up to 769,000 malaria deaths in African children, so more than double the deaths that were occurring. Fortunately, the number has been less, but there has been a 12% increase of malaria deaths. And up to 2/3 of those additional deaths are estimated to have occurred because of service disruptions. So a big problem, but fortunately not as big as we thought. And we are catching up with the situation. And let me finish 5 seconds in advance. Thank you very much.